All right. Good afternoon, everyone. I'm Dr. Madeline Verhofstadt. I'm the Chief of Medicine here at St. Joseph Healthcare Hamilton, and delighted to welcome you to this week's citywide Hamilton Medical Grand Rounds. Next slide, please. St. Joe's is our host site this week, but we've got people, I think, logging in from and representing many different locations. Next slide. And we will start off with a land acknowledgement today that particularly acknowledges the land that St. Joseph Healthcare Hamilton sits on, which is on the traditional territories of the Mississaugas and the Haudenosaunee nations. And this is within the lands protected by the Dish with One Spoon Wampum Agreement. This agreement is a treaty between the Anishinabe, Mississaugas, and the Haudenosaunee that bound them to share the territory and to protect this land. Subsequent Indigenous nations and peoples, Europeans, and all newcomers have been invited into this treaty in the spirit of peace, friendship, and respect. Next slide, please. So we have got a double bill for you folks today. Two really exciting presentations from our internal medicine residents. First up will be Drs. Julia Bryson, Matthew Patel, and Meera Shah, presenting about their experience on the Uganda Elective, Reflections from a Block at Mulago Hospital. I'm really pleased and grateful to have Dr. Amanda Huynh here co-hosting with me today, and she's going to give a presentation of this first set of speakers. They will be presenting for approximately the first half of our slot today, and then we'll be starting in with some other speakers who we will introduce once we get to that point. So over to you, Dr. Huynh.
Awesome. So thank you. So I'd like to introduce Dr. Julia Bryson. She is a PGY3 internal medicine resident who is passionate about global health, community medicine, and preserving summer in the form of jam. She is looking forward to pursuing her general internal medicine fellowship at McMaster next year. We also have Dr. Matthew Patel. Matthew attended medical school at the Royal College of Surgeons in Ireland and has enjoyed his core internal medicine training at McMaster. He will be continuing his training as a GIM fellow at the University of Toronto with an interest in medical education. And then we have Dr. Meera Shah. She is a third-year internal medicine resident as well in the McMaster program. She has an interest in nephrology, global health, and clinical research targeted at enhancing patient care.
Excellent. Thanks so much, Dr. Huynh. Meera, Matthew, and I are really excited to be able to speak with you all today about our experiences with the Uganda Elective. So we have no conflicts of interest to declare. Today, we're going to provide you all with an overview of the Uganda Elective and its goals, and we're also going to share some important lessons learned that we took away from our time in Kampala on chronic disease management, medical education, and local perspectives on global healthcare participation. So the Uganda Elective was established 20 years ago, back in 2004. It's an annual elective that takes place over the course of one block and involves 3 senior medical residents from the core internal medicine program, as well as McMaster faculty supervisors. We're partnered with McMaster University, which is the oldest and largest university in Uganda, and our rotations take place mainly at 2 hospitals in the capital city of Kampala, Mulago National Referral Hospital and Trudeau General Referral Hospital. Mulago is the largest hospital in the country. It has 2,000 beds, tertiary care level. All specialties are there with the exception of OB-GYN at a neighboring hospital. It has ICU capacity, CCU, dialysis, surgery, including neurosurgery, and all of the medicine specialties. And they're also advancing to even having transplant programs up and coming. Trudeau is smaller, 200 beds, mostly internal medicine, and these are publicly funded hospitals. They do have private pay wards within them, and as well, most diagnostic testing as well as many treatments are not covered except in special circumstances. And then we also have some opportunity to interact with community outreach clinics, for example, the Access Clinic in Nakaseke District, which Meera will speak about a little bit later on.
Thanks, Julia. So some of the goals of our elective had been to sort of advance the global health knowledge and exposure that we would obtain as internal medicine residents. We also wanted to use this opportunity to create a network in global health and meet colleagues from around the world. We were hoping to also enhance clinical skills in a resource-limited environment that may not be something that we get typical exposure to through McMaster, and also get a sense of diseases and conditions that are uncommon to our population that we treat. And ultimately, it was also an opportunity to cultivate teaching skills in a new environment with many of their junior learners. And that's what we were hoping to bring back to our elective.
We thought it would be helpful to provide some context to our next few slides by going through a day in a life of what it was like rotating through Mulago Hospital. So our day would start at 8 o'clock, similar to here at McMaster, with morning teaching activity every day. This would go on till around 9 o'clock in the morning, following which the morning would be composed of either ward rounds or attending clinic. The wards round were team-based, so we would round as a team. The patients would be clerked by the medical students and then presented by the medical students during the ward round, with the intern and the residents coming up with the plan. For twice a week, there would be major ward rounds where an attending or consultant would be present, and the remaining days of the week would be business rounds, so it would be taken care of by the medical students, interns, and residents, with the attending available via phone if needed. In the afternoon, we would complete tasks similar to here at McMaster, like doing discharge summaries, following up tests, ordering investigations, as well as attending tutorials or providing tutorials for medical students or interns. You can see on one of the photographs that, as Julia mentioned, despite being a public hospital, patients were required to pay for some investigations as well as some therapies, with an X-ray costing around $17 Canadian and a CT scan costing up to $70. And there's also a photograph of one of the dialysis units at the Mulago Hospital.
So for the next section of the talk, we wanted to each individually touch upon lessons that we kind of took away from our experience. And one thing that I'm going to be chatting about was the management of chronic diseases in Uganda. So here in Canada, I think everyone's kind of familiar. A lot of our patient population suffers from NCDs or non-communicable diseases. And historically, when we think of sort of developing countries, we think of infectious diseases as being the most common type of conditions that affect the population, which is still the case in Uganda. However, we wanted to emphasize that when we went on our elective, there was a lot of concerns that now NCDs are emerging in terms of higher prevalence amongst the population. So the image on the top right here just shows that while infectious diseases still account for 54% of the population, NCDs are climbing in number and accounting for about 33% of all deaths in Uganda. And furthermore, premature mortalities from NCDs is at 22% in Uganda, which when you look at Canadian numbers, it's about 10% in Canada. So there is a twofold increase in mortality from non-communicable diseases, which thankfully here at home, we know that we have extensive amount of resources to help treat and manage. That is sort of not the case in Uganda. The bottom three images are just highlighting some trends shared by the WHO about things that will be impacting the Ugandan population. So obesity and things like hypertension are actually increasing in alarming amounts compared to the global trends. And what we've sort of experienced is that there's still work to be done in terms of resources to help manage the increasing prevalence of NCDs in the country. So as we had alluded to earlier, the hospital that we were at is a public hospital. So they did have a public outpatient department that ran clinics. So I just wanted to take some time to share that experience with everyone on this session. So basically, there were some specialty clinics that happened at Mulago Hospital, but there would be sort of one subspecialty clinic a week. So I actually did 4 months of nephrology while I was in Mulago, and the natural clinics happened every Tuesdays. And this public clinic was free of charge for citizens, but they would have to pay for things like medication and investigations and some lab work, although this was subsidized as much as could be possible depending on the hospital's budget. The kind of the unique thing about this outpatient department is that the resources were quite limited. So the picture on the right features myself alongside my Ugandan colleague who is a medicine resident there. And this is what the clinic space looked like. This one room would have 3 desks, and you would be seeing 3 patients at a time with very limited privacy and very little equipment. The only piece of equipment we had in our nephrology clinic was a blood pressure cuff to kind of measure blood pressure. And then basically patients from all over the country, not just Kampala, the city that we're in, would come to this sort of free specialty clinic. And it could range from about 50 to, onward patients a day. Everyone would come at 8 o'clock, and they were kind of seen on a first come, first served basis. While you did have access to some investigations, a lot of the investigations were outdated. So, for example, I met this lady in my visit. I would prescribe her investigations that I wanted, but at her next visit would be when I would be reviewing those investigations. That could be 4 weeks or 6 weeks later. So you are making clinical decisions on data that's not like at the same time. And then the other benefit of coming to these clinics was that a lot of the drugs in the pharmacy that we had at the public hospital were donated by pharmaceutical companies. So it was more subsidized for patients. They could get a month's supply of blood pressure medications, which they may not be able to afford as easily outside the hospital. And some of the sort of challenges with this type of clinic was that there was no allied health support either. And as many of you can reflect, management of NCDs or chronic diseases requires multidisciplinary care and approach. And even explaining how to administer insulin to someone in a very limited encounter was challenging. And I think that does impact the ability to provide care for NCDs. From our experience, we also wanted to briefly comment on this community healthcare worker model. So now you may be understanding that there is this increased need for care all across the country, but a lot of care is centralized in the bigger cities. So in response to this, there's this model of healthcare called the WHC model that has been implemented worldwide. It has been used in Uganda. It's actually been used in Canada, but it was launched in 2001 as a means to empower sort of citizens that are not centrally located to provide healthcare for the population. We had the opportunity on our elective to visit one such center. It was known as the Access Center in Nagasaki, which is a regional district outside of Kampala that did some of this work. And the image on the right kind of reflects the structure of the CWH model. So basically they had citizens of Nagasaki that were trained to help provide NCD testing. So this is measuring blood pressure, measuring sugars, or doing CBCs, but they have point of care testing available for that. Then they would appropriately refer patients who needed management for these things to the Access Center, which is, I guess, a district site where physicians and nurses were available to provide that chronic disease care. And ultimately, you wanted to expand this model by further educating more and more citizens to be able to help provide that healthcare. And the Access Center that we visited kind of had 2 sort of infrastructures, one for diagnosing and managing hypertension, and something unique was also their seniors program. So basically in the Ugandan language, a jeja is an individual who is above the age of 60, so kind of like our seniors at home. And they had a jeja program that had these community health workers provide medications and foods to support the seniors in that community. So we had the privilege of kind of seeing this center and how this model was working, which has been helpful to improve the healthcare disparities that do exist.
So this elective was a really great opportunity for those interested in teaching and medical education. If you go to the next slide. So the undergraduate medical education system in Uganda is a program of 5 years duration where you enter after high school. It's interesting to see that despite having a population larger than ours in Canada, they actually have fewer medical schools and graduate fewer students per year. Both medical students, but as well as dental students, are required to complete internal medicine rotations, which was interesting to learn from dental students on the wards. After graduation from medical school, first-year Ugandan doctors are termed interns, and they'll complete a one-year rotating internship in internal medicine or a medicine subspecialty, a surgical specialty, obstetrics and gynecology, as well as pediatrics. Following intern year, most Ugandan physicians will actually step out of the training scheme and work as a medical officer for a few years. A medical officer is someone who's licensed who can practice independently but is not a specialist. And the reason they do this is that in Uganda, residents actually get paid a very, very nominal uh, fee where they're treated more like learners as opposed to employees. And the salary of a resident is actually not enough to cover the cost of living. And so they'll work as a medical officer to save funds to help cover their costs when they become a resident. Internal medicine residency in Uganda is 3 years, similar to Canada, and they'll complete the same sort of task that we will as a resident here, supervising the care of patients by medical students and interns and completing admissions. As I spoke about, residents in Uganda are there to thanks, Julia, are there for their learning. And so it's interesting to see that they would oftentimes leave the ward round to attend tutorials and stuff and ask for the interns and medical students to finish up the tasks. The last thing I want to talk about is that there's very limited subspecialty training available in Uganda. In fact, they only offer fellowships in cardiology and oncology. So doctors, after they finish their core internal medicine, if they wish to become subspecialized, will have to go abroad, often to the US or South Africa. And McMaster has a very strong reputation of allowing for the Ugandan trainees to come and complete a one-year focused fellowship in some of the subspecialties. We were able to meet faculty there at McMaster University who had trained in hematology, respirology, endocrinology, and cardiology. So that was great to see the capacity building by McMaster. The teaching at McMaster University at Mulago Hospital was similar to our clinical teaching unit experience, where there was a teaching activity every day. A few of the highlights that stood out to us was the mortality and morbidity rounds, where the residents of a particular unit would have to present on the mortality and morbidity of their unit for the past month, as well as highlight the changes they were going to make to try and improve things. There was a journal club every week where a team would present a topic of a paper of interest to their subspecialty. What was interesting is that a recurrent theme of the journal clubs was that the trials and the papers they were presenting often did not include patients of a similar demographics and epidemiology of the patients that we were treating in Mulago Hospital, and there was concerns about the applicability of the evidence. And finally, on Fridays, there was post-mortem rounds, which are multidisciplinary, attended by both internal medicine, emergency medicine, and pathology learners, where they would talk through a case of a difficult diagnostic or uncertain diagnosis through the postmortem. Not only was there opportunities to be involved in education in the undergraduate medical education as well as postgraduate education, McMaster also supports a primary school in Kampala near the Mulago Hospital called St. Martin's Primary School. And McMaster has helped to fund a kitchen equipment facility to allow the students to have free meals at this school. As Meera was talking about the Access Health program, McMaster has helped support the nursing school at Access, which will provide trained healthcare professionals in the rural areas. And there you can see some of the nursing students practicing delivering babies with a simulation model provided by McMaster. There was lots of opportunities to be involved in teaching locally, whether that be didactic lecturing of the medical students and the interns, whether that be teaching on ward rounds, providing feedback on case presentations and highlighting management points, as well as doing bedside teaching with clinical exam maneuvers, as well as procedural teachers. There's also opportunities to get involved in teaching from abroad, whether that be through Zoom tutorials. I know some of the McMaster University students and postgraduate residents joined the EBM curriculum with the academic half days and provision of resources like the McMaster internal medicine textbook, as well as the Red Book.
Great.
So one of the main goals that we had in going to Uganda was to be able to learn more from the local trainees and healthcare providers and administrators about how we, as future Canadian internal medicine physicians, can make contributions to global health in ways that are meaningful and sustainable. And definitely that opportunity was one of my biggest takeaways in having those conversations during our elective. And so I'll just be speaking on some lessons learned on local perspectives on global healthcare participation. One of the themes that arose from those conversations was that local priorities really matter. And it goes without saying that the talent, ideas, and education are all there in Uganda. And that could be seen from everything from the innovative programs like the Access Clinic to the keen medical students that we worked with on the wards. And where McMaster and other members of the global community can really help is by investing in locally driven initiatives, whether that investment be time, financial, or access to networks and social connections. As well, the most meaningful global collaborations are often the ones that center the priorities that are set by the local stakeholders rather than outside plans imposed on local populations that often don't have a fulsome understanding of factors such as cultural context, local resources, basic logistics, or have misguided priorities compared to the actual local needs. Another theme was that longitudinal involvement matters. And one thing that we heard time and time again when we were meeting with folks is that the McMaster partnership with Meera and Mulago is valued because we continue to be involved over the course of many years rather than transient collaboration. And as we said before, the elective has been established for already 20 years, and the only break in that time was a few years during the COVID pandemic. But it's these longitudinal partnerships that really, the reliability of them helps to facilitate ongoing growth locally. And as well, when there's unique or urgent challenges that arise, like the COVID pandemic, for example, established partners are in a much better position to work together as you already understand the context, local logistics, and can act much more rapidly alongside local counterparts. For example, in the early stages of the pandemic, McMaster was able to help in sending a shipping container full of PPE to Mulago Hospital, as that was a big need there. And that response was able to be more rapid because of that established and longitudinal partnership. And then as well, capacity building is a long haul process, and that requires long haul partnerships in order to be sustainable. Presence also matters. We as a group did spend some time reflecting on the costs that were incurred for us to travel to Uganda, everything from visas to transportation, accommodations, and sometimes we wondered if diverting financial resources to investing in local programs or local resources and just supporting from afar would be a more meaningful investment. But nearly everyone that we spoke to felt that being physically present at times was important for multiple reasons, including building camaraderie, having a better understanding of the challenges that are being faced locally, especially sometimes challenges that might not be able to be well publicized, as was pointed out to us by some of the staff physicians. And being there in presence together often leads to a better bilateral exchange of ideas, knowledge, and goals. As well, when we discussed with folks, certainly supplies, equipment, and other kind of physical, tangible support is welcomed, but they might not always have the lasting impact that we anticipate. For example, if they break and can't be repaired locally, or if something like a vitals machine ends up disappearing from the wards. And when you're actually physically present to share in education and research and clinical care together, from the perspective of the trainees we spoke with, that has a higher and more lasting yield to them. And of course, just being together definitely led to a sense of feeling united toward a common goal of advancing health and helping to build those networks in global health. That was one of our goals. Oh, Matt, you're muted, sorry.
Sorry about that. On our weekends and time off, we took opportunity to explore Kampala and Uganda. So from left to right, you can see the Baha'i temple, which was up on a mountaintop and very serene and peaceful compared to the noisy, bustling city. We also went for an evening to the Ontario Cultural Center, where we were able to try traditional Ugandan foods, as well as see some traditional dances from across the country. We also went to see the Uganda Kingdom Ancestral Palace, which is actually the largest traditional kingdom in East Africa.
And at the end of sort of our elective, we took some time to really explore the beautiful country that Uganda is known for. So we had the opportunity of visiting one of the national parks, Meron Falls National Park, to partake in a safari experience, which truly was wonderful to have the opportunity to see. And these are some of the animals that we were able to see up close, and very thankful for that experience.
That concludes our prepared presentation. Thank you, everyone, for listening, and I'll turn it over to Dr. Brahofsek.
Fantastic presentation, folks. Amazing how much you were able to do and see, and the number of connections you were able to make with colleagues there in Kampala and in the surrounding areas during a relatively short period of time, and how much you have been able to take us on a tour of that over a relatively short period of time here during our round. So thank you so much. I'll invite, we do have 2 or 3 minutes in case there are any questions, if folks wanted to either raise a hand or plug that into the Q&A. And while we're waiting for that, I'll just highlight, I'm not sure if you're aware, but the Access program in Nakaseke that you had a chance to visit was started by a physician, Dr. Robert Paliasubla. I saw him there in your photos, so I know you met him, but he had come while he was doing his internal medicine training for a 3-month block that was supported by the St. Joseph's Hospital International Outreach Program, and had then gone on to do a nephrology fellowship at Yale. And he's really become a very important leader in terms of this community program that he's developed, as well as leading progress in nephrology care. And I had the pleasure of just being in Uganda just earlier this month, and he really does, not to say that McMaster takes any responsibility for all of his success, but I think having that international opportunity very early in his career was a very formative experience for him. I'll also highlight, you mentioned some fellowships. One other fellowship on that subject is nephrology. And I'll say that nephrology here at St. Joe's, which just happens to be where it's located, but they've continuously had fellows from Makerere here. And to my knowledge, there's someone here presently, although I don't know that person, so I won't go any further than that. So this is really a fantastic collaboration. I see a comment here from Dr. Ali Prebtani. Shout out to Dr. Prebtani for all of the work that he's done in launching the elective and continuing to keep it a very rich experience. So thank you, Dr. Prebtani, and he's congratulating all of you on a wonderful round.
Thank you.
Any other comments that you wanted to add to the presenting group? Don't want to put you on the spot. So thank you all so much. If there are PGY2 residents or PGY1 internal medicine residents in the audience, hopefully this gives you a great idea of what the experience could look like for those who are thinking of applying. And if that information hasn't come through yet for the upcoming year, I'm sure you'll be seeing a lot more about it soon. Thank you, Dr. Shah, Bryson, and Patel for your presentation.